Welcome, everyone. We're so excited for our journal club today. Future Dr. Steven Brendlinger, who's a pharmacy candidate from Roseman University, who's graduating in 2026, is going to be presenting for us this really interesting journal club on the impact of clinical pharmacist-led AI-supported medication adherence programs. And what's really phenomenal here is just Steven himself. So Steven has such a strong passion for both ambulatory care and critical care pharmacy. He's trained in ambulatory care at Intermountain Health Care Clinic. And then he also has an emphasis when he does ambulatory care in chronic disease management and patient education. And he has done numerous advanced pharmacy practice experiences in critical care, acute care, coming up, and he's in an informatics rotation right now. I feel like Steven is an absolute master at journal clubs, so excited to have him present today. And I just want to emphasize it's so phenomenal to see Steven's impact on patients and how he just has connection be his absolute signature anytime he talks with a patient. So wanted to highlight his influence himself on adherence and chronic disease outcomes with patients and those conversations. But Steven, I'll pass the time over to you.
Perfect. Thank you so much. I appreciate that really wonderful introduction. Actually, it's so funny to hear that in a professional manner. But as Megan said, I'm Steven. It's nice to see and meet everyone. So as Megan said, I had done an ambulatory care rotation and kind of fell in love with it, which kind of led me towards this topic discussion of pharmacist-led innovation in chronic disease management, and then tying in informatics into that, which didn't know anything about prior to, so really excited to dive into this with everyone. But yeah, the official title of my article is The Impact of a Clinical Pharmacist-Led AI Intelligence-Supported Medication Adherence Program on Medication Adherence Performance, Chronic Disease Control Measures, and Cost Savings. So definitely a mouthful. I have included an abbreviations index here to help us throughout the slide as we navigate going forward. I did include some in there just for time's sake. I also have the official citation from my article. And just to review the authors involved, we had Charles Worrell, who is a PharmD student at the University of South Carolina, Dr. David Shirley, who is a PharmD Associate Professor for the Department of Clinical Pharmacy and Outcome Sciences at the University of South Carolina, Dr. Jeff Bullard, who is an MD with Medical Officer at Stellus RX. And then we have Ashley Dow, who is the Business Intelligence Analyst for Stellus RX, and Dr. Taylor Morissette, who is another PharmD Assistant Professor for the Department of Clinical Pharmacy and Outcome Science at the University of South Carolina College of Pharmacy. This was funded by a grant from Stellus RX. However, authors declared no relevant conflicts of interest or financial relationships. And Stellus RX, just to give a little context there, is a pharmacist-led clinical support with guidance, education, and coaching. They provide a personal pharmacist to each patient. And on their website, they state that Stellus RX combines teams, technologies, and trust to change the trajectory of health and costs for individuals and at-risk populations. So very much for the people, which is good to hear. Going forward into the background, some information about chronic disease states. As the U.S. healthcare system spent $4.9 trillion in chronic disease state management, as well as 6 out of 10 people have at least one chronic disease. So very relevant. People around you very much probably have it. We're all in healthcare, so we have some experience there with it. And then about 50% of people have estimated medication non-adherence, which becomes an issue in terms of long-term care. So some clinical motivation context to this study. Chronic disease states are a leading cause of illness, disability, and death in America. Non-adherence specifically increases hospital admissions, misdiagnoses, and increased risk for morbidity or mortality. And it also contributes to 10% of hospital readmissions, so a decent contribution there. And some involvement here is the Medicare Star Ratings, which are weighted on adherence measures by about 1/3, which is a significant amount. And just for context too, 1 star improvement translates to 8 to 12% enrollment increases. So there is some kind of financial incentive there as well. Health information technology advancements really increase exploration of avenues to increase adherence. So that's where we're hoping to kind of see some AI enhancement in here. But also in relation to the article, as well as just reported by the Center for Medicare Services, their top conditions were hypertension, diabetes, and hyperlipidemia, which is what this article focuses on. So kind of double dipping there, which is nice. The Medicare Star Ratings are important for informed patient decision-making, as well as provider accountability and incentive reimbursements. So there's some motivation there to have better ratings as well. And overall, there's a really good innovative opportunity here. Clinical pharmacists are uniquely positioned to bridge gaps between patients, providers, and offer effective medication management through technology-enhanced interventions, as well as just improve healthcare cost savings for patients by improving adherence. So the primary objective for this study was to evaluate the impact of an AI-supported pharmacist-led medication adherence program on medication compliance in 3 disease states, which were hypertension, cholesterol, and diabetes. Some secondary objectives were disease control measures such as A1C, a cost analysis to quantify healthcare expenditure between adherent versus non-adherent patients, as well as star ratings to assess the impact on Medicare Star performance metrics, and to measure gap identification and closure rates. With this, there's an overarching research question of, can a technology-enhanced pharmacist-led medication adherence program leveraging AI analytics and personalized patient outreach significantly improve medication adherence rates, clinical outcomes, and reduce healthcare costs in chronic disease management? So really multifactorial here, which is really cool. So the study is a quasi-experimental, multi-center retrospective study. So there's a pre-implementation period, which took place from January 2019 to December of 2019, and then the post-implementation, which is January 2021 to December 2021. It took place in Central Texas Medicare Advantage population using Medicare claims data and descriptive statistics analysis. Inclusion criteria included those of 18 years and older and had available Medicare claims data with chronic conditions associated with diabetes mellitus, congestive heart failure, COPD, hypertension, and hyperlipidemia. This population was then grouped into segments, group 1 including single conditions, group 2 multiple conditions, and group 3 all 5 conditions. Overall, there were 10,477 patients in the population, so pretty significant. And of this, 60.6% were in at least one medication measure, and 2,762 had actionable adherence gaps, so a pretty significant amount of people as well. And it is of note, too, that they ran a pilot program before implementing in a larger population, which we will discuss at a later time as well. So for the technology side of this study, AI used a machine learning-based predictive analytics for risk stratification and prioritization. This used pattern recognition to identify patients at high risk of non-adherence based on their claims data patterns, pharmacy bills, and demographic factors. So kind of looking holistically. Kind of the way it was structured was that there was data ingestion, such as like Medicare claims and pharmacy data, and then AI performed an analysis to stratify and prioritize patients, which then generated a queue for the pharmacists, and then pharmacists performed clinical reviews that were comprehensive. They performed outreach interventions, such as to do chart reviews, outreaching to dispensing pharmacies, and even as far as patient interviews. So a very proactive approach to it. So some integration capabilities into this was that it was a multi-stakeholder data integration into a single data model. And then it was hyper-efficient data processing to create a provider-wide coverage, which is where we get that large population from. There were real-time analytics for gap identification and closure tracking, monitoring for everything. There was predictive modeling for intervention prioritization, and a closed-loop feedback for continuous improvement. So pre-implementation period in 2019, this is where we had the standard of care without AI-supported intervention. We had traditional monitoring through claim reviews, limited outreach. There was more of a reactive approach to medication gaps, so more so when they were at appointments and then reaching out there. and just manual prioritization of patient adherence. This established medication adherence rates and clinical outcomes for comparison, so it is essential in this scenario. And then our post-implementation period in 2021 had AI-enhanced gap identification using those predictive analytics, and then had a systematic pharmacist review of these prioritized queued cases, and then the personalized outreach with provider collaboration for comprehensive solutions, and continuous monitoring until the gap was closed. This overall had a proactive, technology-enabled, pharmacist-led intervention model. Mouthful, but super important in this scenario, especially for chronic disease state management. And then more about the pilot program was that it had 338 patients, and this just specifically utilized statin adherence in patients with diabetes. So that's the SUPD you see in the bottom there, and then statin use in patients with cardiovascular disease, which you see that SPC at the bottom there. But overall, in this little pilot program, there was 100% comprehensive assessments completed. And just within this subgroup, there were 3 to 4 Medicare Star to 4 Medicare Stars improvement. So roughly the adherence in this category improved by about 3% in each group. So for our primary outcomes of the larger group, it focused on non-insulin diabetes medication adherence, the RAS inhibitor for hypertension medication adherence, and statin use in cholesterol for medication adherence there. And it categorized things based on a portion of days covered, that's that PDC, of at least 80% within the time frame. And that was our threshold there. So secondary outcomes included clinical control measures, such as the A1C control, which in the study standards, and I think it was according to the Medicare standards, the goal achievement was to be less than 9%. Medicare Star Ratings for the statin use in patients with diabetes and cardiovascular disease, as well as economic outcomes such as total medical expenditures per member per year or monthly. We got both results. And then the cost differences for adherent versus non-adherent patients. And then there were some adherence classifications. So for patients who were classified as never adherent, they were not adherent for all eligible measures, as where sometimes was that 80% for only one measure, so one disease state, or always, which was for all eligible measures that they had disease states for. And so some results and key findings. Sorry, Megan, do you mind advancing to the next slide? Thank you. So for the primary adherence outcomes, we saw improvements in all 3 categories. So for the diabetes adherence, it was plus 6.4% increase in adherence. For hypertension, it was 5.9%. And for cholesterol, it was 7.9%. Now these percents seem small in theory, but for a population size of 10,000 patients, and then when you expand that to more, that is definitely important. And again, for ethical considerations, when you have anybody, like, of course, you want to increase adherence. But overall, all 3 measures achieved performance beyond 5-star cut points, which is awesome. A1C goal achievement increased by 6.2%. And so of that, 470 patients touched the A1C goal, and then 378 finished controlled with 59.5% maintaining. Beyond our 5-star performance, we really excelled in the medication adherence in hypertension and diabetes, as well as the statin use in patients with cardiovascular disease. We reached 4-star performance in the diabetes medication adherence and the statin use in patients with diabetes. But overall, we saw improvement in all of these quality metrics, which is awesome. And then for the economic impact, which of course everyone cares about money, so that's important too. But this is where we saw significant savings. For diabetes, we had a cost savings of 32%, which translated to $3,338 per member per year. And then for hypertension, it was 31% savings, and hyperlipidemia, 25% savings. Diabetes by far took the board there, which no surprise, diabetes medications are expensive, and typically patients are on multiple of them. So that's where we kind of see a huge increase there. But overall, we saw a 47.3% direct gap closure rate, which is awesome. And then 100% of gaps were at least researched and acted upon. So for the strengths and limitations of the study, starting at the study design, we had a large real world population. With that, there were 10,477 patients in the main group. That is a huge sample size, providing external validity. And then we had comprehensive coverage, so multiple chronic conditions and all medication-related STAR measures for each one. There was a multi-outcome assessment using adherence, clinical control, economic impact, and process metrics. So a lot of data within this one study, which is cool. And then we had the appropriate comparison period, excluding the 2020 COVID data due to the confounding variables that could result from that. Now, of course, with every study, there are limitations within that. I have critiques. One of them, the quasi-experimental design, it lacked randomization. So there's some potential there for selection bias and some confounding variables. And then for the before and after comparison, there was no concurrent control group. So there are secular trends and external factors that might potentially influence outcomes. And there was only utilizing the single health plan, the Medicare Advantage healthcare plan for Central Texas Medicare Advantage population. So there's some like generalizing there that we don't necessarily want to do for all populations. There also, yes, excluding the 2020 data is appropriate. There also is concerns with that 2-year gap, creating a little disconnect there. Healthcare landscapes tend to change pretty rapidly throughout time, and that is a pretty big period where we had a lot of changes going on. Even in 2021, we were still kind of slowly coming out of our seclusion there a little bit. So definitely had to take that into account. Now for the clinical and operational implementation, we'll start by discussing the pharmacist-centric workflow. So with this, I found this to be really positive, and we can kind of find a lot of growth here. It's pharmacist-led, but incorporated appropriate use of technology in order to enhance the pharmacy process and identified problems to troubleshoot solutions, optimizing outcomes, maximizing workflow, which of course we love. I'm an organized king. I love to organize. So having some flow there, I appreciate it. It also incorporates other professionals involved in the care. So you're getting proper communication and maximizing patient outcomes with multiple professionals involved in the patient's caretaking. Then there are some technology and implementation gaps within the article. This is where I was slightly disappointed in the informatics brain, but I'll continue to go into that throughout the presentation. There's a lot of like replicability concerns due to the lack of detailed intervention protocols. It really lacks details in terms of, like, it provided like an AI black box with limited descriptions due to their like algorithm specifics or like training data and validation methods. And then this would provide a lot of technology dependence on the Stellus RX platform. Like there needs to be other platforms out there. There also is implementation limitations with insufficient information about like the staff training, the system configuration, workflow integration. This really changes a lot of your day-to-day process. And continuing in the data and analysis side, some strengths for that, it utilized objective medication fill data, reducing self-report bias. We can, of course, I see this at work all the time. I do med histories at work. People are going to tell me what they think the medical professional wants to hear, which is unfortunately a part of that white coat symptoms there. But then we also have the standardized metrics, which use established Center for Medicare Services quality measures. So that per day analysis. And then the economic analysis using direct cost comparison between adherent versus non-adherent patients. That was pretty strong and solidified data. And it had the longitudinal tracking with a year-long implementation with sustained improvements. And then, of course, getting into the biases here, we have the claims data limitations. Now, it was billing-focused data, which may contain inaccuracies, missing information, or miscoding. And then there's, of course, the assumption bias where we assume prescription filling equals actual medication taking. It doesn't account for adherence behavior. It doesn't account for hospitalizations. I have it all the time where patients don't take their medication for a couple of days and then we'll make up for it and take it all at once. Like there's certain medications where patients will do that. So it doesn't take that into account. There's also some survivorship bias or performance bias because, of course, you have increased attention to your adherence. And so people are naturally going to improve on that knowing that they're being monitored. And there also is some clinical relevance here. We have the patient-centered outcomes, which is super important. There's the A1C control and clinical disease state management in a more appropriate manner. Some quality improvement in terms of patient care with measurable Medicare Star Rating enhancements. There's the cost factor where we see reductions, and the scalability due to the pilot program implementing into the full population, which has seemed very successful in this case. There's some financial considerations here. The study was funded by Stellus, so there's some potential bias towards positive results. However, if people are going to invest in things that they think are going to have specific outcomes, if you're not involved in this field, why would you specifically invest in a study in it? Makes sense. And then there's some author conflicts with multiple of them being employed by Stellus RX. So there's some financial interest in outcomes there. And lacks intervention for cost accounting in terms of implementing this new analytics. And there was no IRB approval. However, it's not required. They did, however, were transparent about it. They stated it wasn't required, but they did submit for it. They just never stated whether or not it was approved. I don't know if that happened after or before they posted the study. So from a clinical pharmacist perspective, I love that it has that proactive care. We see the shift from reactive to predicted intervention models. That is something we're kind of in this zone of healthcare where we're seeing that be implemented more, which is awesome. And so this kind of can help aid in that, which I'd love to see. I like that it has personalized outreach. And so you're getting tailored interventions to this individual patient. So you're able to kind of connect with them on a deeper level, and I think build more healthcare trust with them, which is essential to a patient too, and knowing their circumstances to really optimize their outcomes. But overall, it's a holistic medication review and incorporates proactive approaches to adherence and encourages care team collaboration. So I can't complain. The AI incorporation really gives insight to like at least starting points for compliance. So it can give suggestions for minimizing pill load, bubble packs, patient financial assistance, medication delivery. So it really gives us a starting point, if not direction on where to go with this patient. Some critical concerns with it are the alert fatigues with many gaps, especially when first implementing this program. You're going to have a huge list. Like it's just going to happen. And so until you narrow that down, you're going to continue to get alerts. That's going to seem exhausting and scary. You might have this initial sense of feeling overwhelmed until you close a portion of those gaps. But there are some confidentiality concerns for extensive data analyses here. We can get into some like touchy HIPAA stuff, but I'll go into that a little future as well. There is some potential too for relying on algorithms. We can kind of tend to neglect the clinical side of this. However, it does have a good amount of clinical involved when you're doing these case analyses as well, but also still kind of knowing your foundation there. It could cause some resource strain because you're increasing your pharmacist workload here with your intensive case analyses. And so you may have impact on other clinical services that the pharmacist can offer, which becomes tricky. But overall, it is clinically meaningful due to the improvements rates, which translates to real patient benefits, and it's awesome. And it did exceed typical MTM program results and approach levels that are seen in clinical trials, which is cool. So some key success factors are pharmacists trainings, provider buy-ins, as they are a big part of the collaboration here, patient engagement. It requires communication strategies for diverse patient groups, and then resource allocation, because it requires significant pharmacist time investments for these comprehensive reviews. And with this, we kind of see this paradigm shift from episodic interventions to continuous AI-enhanced medication management. It really enhances the role in medication intelligence and creates data-driven decisions so we can do the prioritization of clinical interventions. And it's scalable, which creates this population-level optimization here, which is more than ideal. And it's outcome-focused, so it shifts from this process metrics to patient-centered results. And then from a pharmacy and informatics perspective, which of course that's what we're here for, we see strengths in the Medicare claims standardizing comprehensive, its objective data sources, pharmacy claims, which have accurate fill dates and quantities for the calculations, the multi-stakeholder integration, so it combines payer, provider, and pharmacy data. So again, that collaboration factor and getting the most accurate interpretation of everything. And it just has a really large database with a population level capability here. And then we draw some concerns and limitations with the potential for coding errors, missing data, lag time, lacks physician notes, patient preferences, contraindications. So kind of the deeper patient level here, which hopefully with some adjustments we could eventually incorporate. Again, that fill does not equal assumption or does not equal adherence assumption. The interoperability gaps where we have limited integration with electronic health records, especially across different softwares. But overall, it has a heavier reliance on administrative data without clinical validation mechanisms, which is where we hope to see those improvements. The workflow integration analysis, we'd want to see the automated claims processing, the AI stratification, the queue generation with prioritized tasks, the pharmacist case analysis, and then really the outcomes monitoring and algorithm refinement to really give us the most optimal outcomes here. The integration gaps is where we see that like the electronic health record integration, clinical decision support, or existing MTM workflow coordination here. So that's where we want to see some improvements with time. So continuing on that front, the capabilities of this is the claims pattern analysis, continuing to identify trends, the risk score generating, intervention prioritization, the workflow automation, performance tracking. This provides insights into system effectiveness. Now, some gaps we want to see being worked on are the algorithm transparency, training data description. So we want to know the source and characteristic details, validation. We want to know the reliability of outcomes, the bias detection and mitigation. We want to address that. And then performance metrics. We want to know how effective this is. We're only getting a year-long process, which is a good amount of data, but we want to see it being implemented over longer periods. And then we have this black box problem of the insufficient algorithmic transparency, which really limits the reproducibility and clinical trust in this case scenario. The positive indicators for this, the task completion and good system usability and pharmacist adoption here. And then some missing elements are the user experience, training requirements, system performance, and cognitive load assessment. We'd want to know more on that front, which again will go to show how easy it is to implement this in the daily workflow. And so kind of progressing on the scalability, we see proof in the pudding here where we implemented from the 338 patients to the 10,000 plus, which is a 31 times scale up. So they really tenfolded that sucker and went with it. We maintained performance throughout this scaling up, and the efficiency continued with the 100% gap processing, even with the larger volume. Maybe with that, we'd want to know how many pharmacists were implemented in this process to know kind of the patient to pharmacist ratio there. The cloud architecture, Stellus RX, has a platform that's designed for multi-client deployment. So if we use that system or another one, hopefully we can kind of continue that. Now, the concern with this is the pharmacist resources. So like linear staffing requirements. Do we need to implement different pharmacists for different levels within this level of care if we implement this? The data infrastructure. So it's got complex integration, which increases more so with adding in health plan diversity and more health plans. We see some implications there. It would need for customization for each implementation, which requires significant configuration for the pharmacist and for the informaticist creating the software. There's some cost scaling. We don't know the cost of licensing and implementation, education. There's going to be trainings that are probably paid for the employees. Now, in terms of interoperability, we want to comply with HL7, FHIR, electronic health system integrations. We want to make that flow as smooth as possible, and that's something we don't really get in this case scenario. We want to kind of make sure the interface capabilities can optimize workflow and be user-friendly. And with that, we'd want the pharmacy system interface for real-time data and a seamless workflow. So for this, we would need really the data mapping where we have the claims format in a standardized way, system configuration where the rules engine is customizable for patient optimization, a workflow design that's site-specific, staff training, so system education, and then performance monitoring where we have outcome tracking set up. These would be really important, as well as like maintaining HIPAA compliance as we have a multi-stakeholder data sharing, which requires crazy privacy safeguards. FDA oversight to make sure that we're being compliant there. Want to be in your state's jurisdiction for practice acts as well. Your quality measure alignment, your data governance for the AI algorithm updates, and patient data use as well. So some of the ethical considerations we have here, we have the improved patient outcomes, health equity, which reduce disparities in care, and then resource optimization, which is really a huge gap for patients especially. I've noticed in AmCare Pharmacy, we really learn a lot of resources, but I think to have these available through maybe an AI generator too will give some really good opportunity for both pharmacists and for patients as well. Hopefully maybe have more transparency there. Now, some concerns with the algorithm bias, the privacy concerns using explicit patient consent, autonomy issues, and then some commercial influence. Obviously, it's vendor-funded research, so we have some objectifications there. But the financial impacts, there's immense cost savings for patients and medical expenses. The return of investment in this scenario is unknown, as well as we kind of had some assumptions due to like the STAR bonus increase, and so that has some potential for increased revenue. But again, we have to factor in technology costs, personal costs, opportunity costs, and then that revenue impact as well. And so overall, it demonstrates feasibility of AI-enhanced pharmacy-led population with health management with measurable clinical and economical outcomes. So we see the adherence improvement, the A1C achievement, the cost reduction, the care quality goes up in terms of Medicare ratings. So those are all really important things that could transform a patient's healthcare experience. There's high relevance for the Medicare Advantage organizations seeking improvements. There's large population health systems. Clinical pharmacists are definitely a big one. And then like pharmacy informatics, because there's, of course, the technology implementation here where we're kind of seeing a boom come in now. However, there are limitations for smaller practices, or this is not really implementable for acute care because it's more geared towards chronic outpatient management. And then we have like non-Medicare, we'd have to kind of implement different routes for that or fee for services. So then the immediate challenges we would experience is the technology aspect of it. We would need a specific vendor relationship with Stellus RX to kind of duplicate this exact scenario. And then there's insufficient detail for independent replication. So again, we need more data and kind of doing our own trial and error. And then it's unclear for staffing and technology investments that we need to make, as well as the training protocols. But this is where we can kind of see, again, another paradigm shift of traditional MTM programs to an intelligent, automated, pharmacist-supervised medication optimization system. And so you can optimize patient care with that. So some future direction and research needs to really minimize those knowledge gaps. We should do a randomized controlled trials with multi-site validation. We would want a cost-effective analysis, some algorithm validation with transparency, and some more long-term outcome data. Now, with this, for training protocols, we'd want standardized pharmacist education curriculum for AI-enhanced practices specifically. We'd want a workflow integration, so no best practices for an electronic health record and clinical system integration, as well as organizational strategies for the technology adoption and culture change. Technology changes tend to scare people. Also speaking from experience with Intermountain going from the iCentra to Epic, we're all a little scared about that happening this weekend, so very applicable there. We want to see more quality metrics, so performance indicators beyond adherence rates. I personally would like to see more statistics on, like, say for the hypertension one, I'd want to see statistics on the change in blood pressure. For statins, maybe the change in LDLs to kind of see how compliance makes a difference there as well, instead of just A1C for diabetics. We'd have to have stakeholder engagement, so provider, patient, and payer acceptance factors here kind of is multifactorial in that sense as well. And then for scalability, we want to see resource requirements and an implementation timeline. And so I have a list there, I won't go through it all, but AI enhancement ideas and then some good integration improvements that could be made going forward with further research as well. And then I also have some thought-engaging discussion questions here. So off of hand, are there any that specifically reach out to you that you would like to answer, or any specific questions you would like me to answer? I'm down for either or.
Ooh, I like that, Gutsy. I like that. So I do like the question, what role patients play, that number 4, in AI-driven medication management decisions. I am so curious your thoughts, and I'm happy to speak to it as well, and we can just dive right in.
Yes. So my thoughts with that question is one of my biggest experiences out of ambulatory care in terms of hopefully optimizing the best outcome was utilizing motivational interviewing. And so I think through that, an identification of patient-specific goals while being educated by your pharmacist, your AmCare pharmacist, and or your provider, I think we could maybe do a customized algorithm based on that as well. And so then that's also, yes, it's AI driven, but it's also patient oriented to hopefully maintain that autonomy, keep our clinical side of decision making, and then just have better patient adherence and patient outcomes.
Ooh, I really like what you talked about, like the how autonomy is the role that patients should play, like having that preference and choice as a big piece of it. I do think it's so interesting to look at how AI strategizes risks or flag gaps.
Yeah.
And it's very algorithmic, right? But we know humans do the darndest things. So it's very hard to predict what a human necessarily will do. I mean, you can kind of get like large, like bell curve indices of like, okay, most people are going to do this, but that's not how healthcare is, right? Like we want every patient to be successful. And so how do we use AI in a way that it's helping us personalize care for patients as well is kind of what I like to think about. And how do we get AI enough context in order to do so? So it's kind of a fascinating approach. I do think patients, one thing I find interesting about being a pharmacist is often you have to educate patients on how to be a patient as well. Because I really like during the presentation how you said, like, you know, patients tell us what they think those with white coats want to hear. And I thought that was a really phenomenal point, because sometimes patients don't realize the impact of not sharing certain things, or we're so question based in healthcare. Like the only information we'll ever learn about a patient is honestly what questions are we asking, and are we remembering to ask every question, like that type of thing. So I think AI can help fill some of the gaps as far as, oh, like we as humans are forgettable, so maybe we forgot to ask something. So could AI come and say, oh, remember to ask this question, or this seems to be based off of what we know about this patient thus far, like we need additional personalization information about this patient. So I don't know, it's a fascinating question, and I love your answer, and hopefully just adding a small amount of color there.
I'd even love to incorporate some way, like integrate it into like a CGM or like Fitbits and Apple Watches and things. Like those really give us such insight for day to day. Like when I was at my AmCare rotation, we would utilize CGMs for patient education. So we would use that 14-day report, the Libre report or G7, whatever it be. And we would physically show them what their trends were and ask about like a specific recent day about like what did you eat here? Because that really showed a large spike, and that's why it was harder to control. So I even think using it from a patient education perspective has a huge vantage point here as well.
I love that. I love the show and tell method. Is always going to be hopefully such a successful way to connect with patients. There's so many learning styles out there too. It would be interesting because learning and teaching styles, right, don't always match when you have someone teaching, someone learning. So it'd be fascinating to see if AI could help support pharmacists that are trying to teach a patient with ideas of how to connect with them in the way they learn also, or like give that tip, like, hey, like, is there any way you can use like real life devices to help characterize this real life data and trends? And I love that idea significantly. This other
for treatment resistant patients, sorry.
no, feel free to interrupt. Treatment resistant patients, I love. Actually, that brings up kind of an interesting thought. So adherence is so important, right? And the goals they studied are interesting, like A1C, but everyone has that goal, right, of helping impact A1C. And so you also have other multimodal strategies in play of how many medication changes did someone have to navigate as well to get those A1C results? Because we know not every patient responds to just monotherapy in diabetes to impact that A1C. Sometimes we're like adding on therapies. And so
lifestyle modifications.
Yeah. So if we all have that same goal of like reducing A1C, it's interesting that they're like, oh, our adherence AI did this.
Yeah.
But they didn't account for, at least I couldn't see that they accounted for like the level of other interventions out there. I don't know. What was your thought there? Kind of thinking
that
through
was something where reading this, I like the foundation it lays, but there are lack of data or maybe research points, or maybe they just weren't included. But like I said, the lifestyle modifications play a role in A1C, and that's a huge factor in the AmCare setting. We educate so much on that, and this is not accounted for in this specific study. And I don't know if that's accounted for in the AI algorithm that they plugged in. There's a lot of missing data there that I couldn't even find on the Stellus RX website when I was using my little investigator skills.
Yes, gotta Sherlock Holmes it.
I would love to see the AI role in that, even in terms of the non-pharm interventions.
Oh, that's such a good thought, especially our role as pharmacists, our therapeutics as a whole, pharmacological interventions, non-pharmacological interventions, lifestyle interventions. It's the whole kit and caboodle. And so it's really hard to say what actually did that. So it's something very important to keep in mind, especially because of how heavily this one company's style was analyzed. Not, there was no real control group necessarily. We're looking at changes. I mean, would you have seen those changes if you were just looking at a control group population? I don't know. I mean, it's hard to say.
Yeah, and that's where they could have maybe have the control group with the same diagnoses, but maybe without the medication adherence and solely implementing lifestyle modifications. Maybe that's not really ethical, but but like those kind of having both of those, I think, would be really cool. And I mean, through my experience, a lot of people didn't want multiple medications, so really minimizing your pill load, as well as to that extent, you're minimizing financial burden too. So it's kind of, again, the double dipping situation there, when you're maximizing adherence and maximizing non-pharm and kind of really optimizing for patient, I guess, based on their needs more so though.
Yeah, well, that's really interesting. So if I was to kind of go off book here and ask you a question that's not here, I'm sorry, I'm going to go a little off book, and it's related. It's related. So let's say you had your own ambulatory pharmacy clinic practice that you're running, and this study comes in, and you have like your docs and pharmacy team are really excited about this study, and they're like, okay, how do we do this here? What goes through your mind? Like, do you say like, yes, this is worth the investment in this tool, or would you look at other ways to increase adherence? Or like what goes through your mind when you're trying to make that decision of how do you implement this type of study?
Oh, that's a tricky question, because the excited and innovative brain side of my brain says go for it, but then the practical side's like, okay, we need to have a plan, we need structure.
Yeah.
And so I guess
Yeah.
I would have probably an open group discussion on this in terms of practicality, implementation, how we all feel in our confidence to handle technology changes, practical things like that. But then also maybe asking what the AI is doing, because maybe with that, it can go through electronic health records and look through notes and see reasons for non-adherence and implement patient-specific suggestions to help kind of also take off the burden of the case review load. I definitely think pharmacists need to double check that and verify. But if you're an established AmCare pharmacist with this patient base too, you kind of know the patients. I mean, when I was on rotation, my pharmacist had patients who had been with for 10 years. He had patients who had been with for 6 months, and he had multiple conversations with them and knew their behaviors very well in terms of kind of guiding the goals for that visit. So I think AI would have potential to kind of guide that even.
Ooh, that's fascinating. Well, and I think earlier, outside of this conversation we're having here, so for everyone tuning in, we were having a conversation about, what are all of the services that pharmacists provide, especially ambulatory care pharmacists, that patients just have no idea about. And so I like what you're saying, like, could there be a bridge or some sort of, AI support to even get people to realize what services are at their disposal or that they could get access to, what's covered for their insurance. I mean, there's so many applications for what you just said, and I love that approach. I think it's really smart, really smart.
Thank you. Do you have any other questions for me?
Ooh, well, one from your slide here. So the first, is it coral colored? I feel like I might accidentally out myself as colorblind sometimes. It's like, I don't know if I'm colorblind or not, but maybe it's coralish colored. But how do AI enhance pharmacist interventions compared to other population health management strategies is such a phenomenal question. Because again, when we're thinking about like in your clinic, I think that was your approach of, okay, like how do you talk with the team? What matches the style of care that we provide? Like what's everyone's preference? What are the specific problems that you're struggling with the most? And where do you want to resource it? Kind of get opinions from the group. I'm just curious, what other population health management strategies do you think would be effective here as a substitute? And then do you think this AI enhanced approach is the right way to go?
And see, this is where I see potential even for, so instant brain thought here. Pain management is kind of a big one. We see both inpatient and outpatient. I've noticed the whole MME speculation here, but I mean, obviously we have multiple CNS depressants coming into factor for people who have a lot of opioid use. And it always pops up every time the notification for drug interaction, but it doesn't say, oh, this patient is also on these other CNS depressants, how long they've been on them for, is this likely contributing to their tolerance? So maybe AI has the possibility to also kind of, I don't want to say dismiss those notifications, but maybe provide more information in them and more readily available to expedite the research process. And that just makes it a little bit that much easier to help this patient, especially when they call you on the phone and you're having to do a quick answer. You can give them a short answer right away or be like, hey, let me just look this up and call you right back. And then they're not waiting all day long and you have minimal time throughout your day to do that research of the patient review. And it just can kind of optimize that workflow at the very least, which I think definitely is helpful in terms of any form of medical field.
Oh, absolutely. Oh, I love that idea of how do you even just surface information at the right time? Or, I mean, looking in the, prescription databases that we have for drug monitoring as well. I mean, we're doing a lot of creative approaches to search for names, to see what might be going on, to see who might have filled scripts and like, is this okay to fill? There's probably an element of where an AI could pull that information of all the creative ways to approach something and then give you like a
Like a trend analysis almost.
Yeah, like a certainty of like how certain it is that that's that patient, and that way you're not like going through and trying to get creative every time. Like it's just pulled through, and then you can analyze it versus kind of approaching it at first
Yeah.
blush, like trying to just figure it out. That's a really cool idea. I think everything you've said has been a really cool idea and should instantly become some sort of tech tool. Steven, you're going to become a tech mogul. I can feel it.
The innovation's really flowing after going
Yeah.
through this article.
Well, we should talk about are there some cool tools we could do for the rest of the rotation too, like as a result of this? This is very cool. Are there any questions you want to get to make sure we don't skip anything? Like, did you have any passionate answers wait in on the other side?
Well, I guess I want to pick your informaticist experience brain. I'm going to go with question number 2. How would you modify this intervention for implementation in your practice setting, and what barriers do you anticipate as an informaticist?
Ooh, what a good question.
It's a vague and broad question a little bit, but
no, those are the best kind because you never know what you're gonna get. I really do think you did a really thorough informatics analysis yourself in this article, which was really good. I'm trying to think of, from my experience, I think part of what the intervention lacked was any sort of direct EHR workflow. I mean, it seemed like it was a separate vendor platform. And anytime you have a disconnected system, you're increasing the amount of systems of the users having to log into. So that could, really limit its usability. The other thing is, I think having some sort of tiered task routing would be important. So there was a lot of focus on what pharmacist interventions were in this tool, but I mean, technicians are a big piece of how pharmacy gets done.
Yeah.
And so I don't know if I saw enough like multi-role approach to how we help tackle some of these problems. It kind of put it all on one profession. If I was reading it right, I might not have been reading it right, but it felt like it was very pharmacist loaded and it didn't really have a role for pharmacist extenders. But again, that's how pharmacy gets done, or pharmacy interns as well. I was going
to add to it, and that's a tricky and loaded part of that too, because from what I observed, and again, it's limited to the little glimpse that I had of it for my 6-week rotation, there weren't really there was because I was there, but on times where there's not an API student, it really was solely on the pharmacist. They didn't have technicians in the AmCare setting or anything like that. So I guess implementing it in other settings is where I'd love to see that interprofessional ability, like with other professions.
Yeah, well, and I do think like technicians could absolutely have a role in ambulatory care. Like it's just kind of funny the way we're still so new, right? This is our first deep dive in partnering with physicians in the ambulatory care setting and helping support them from a medication management perspective, like we do in the community with retail pharmacy, or like we do in the hospital. There's kind of this gap for clinic visits where physicians just don't have us, and that always feels really tricky. So it's exciting to see where we could be. But to your point, I also don't know if I saw enough about like what their clinical decision support looks like, of how those interventions come across, because part of it like is how good are you at telling someone there's a decision point, or and are all of those false, true positives versus false positives. They didn't really give us an indication of like, was someone acting on an intervention, but because of the tool design wasn't really there or shown, we just don't have an indication of, we're just assuming that every intervention was right. And so, I mean, no profession has 100% rate of accuracy. I just don't think that's possible. So it's kind of fascinating that it's almost like an assumed rate of positivity. They didn't really give us a specificity or sensitivity of the decision support or intervention support that was there. So those are kind of the things that kind of run around my mind is like, okay, there are some like clinical implications there. There's also some, do we have the right person doing the right role implications? But that's kind of how I would answer. Barriers though, so interoperability again, though it'd be nice if to talk to like EHR connectivity was my first answer out the gate. I don't think it's a clear route of how that happens. It's very difficult to make tools interoperable. I did like the Fire APIs and the CDS hooks that they mentioned in the article, but there's still such like it's going to look different. It's going to feel different. It's not one continuous tool.
Yeah.
And then cost sustainability. It's unclear. It's unclear how this would impact the finances of an ambulatory care practice because you're hoping most of your budget goes towards your people.
Yeah.
Tools are really hard to justify in that environment. So it just wasn't clear to me how it was anything beyond soft cost value. Like, am I getting hard cost value? So I don't know. It's a really tough conversation.
Yeah, I agree that there's many moving elements that are missing to kind of see that like replication process there. And my interpretation is like it seems very specific to the Stellus RX platform, which almost seems like its own health system. And so kind of seeing that in play more wide scale, I think is what's missing here. Like it's almost like we would need like an electronic health system to like add an AI extension with this function to it. Like that would be kind of cool.
Some sort of iframe compatibility where it just kind of lives in there. Yeah, I love that idea. Well, I know we're right at time, so I'm gonna just make sure to flash up the resources slides for the participants. But Steven, incredible job, and thanks everyone for coming. I'll stop the recording.